Good afternoon. My name is Tim Poe. I'm here with UNC Cancer Network and the Lineberger Comprehensive Cancer Center on December 18th, 2019 for our Medical and Surgical Oncology Lecture. And just a heads up that starting in 2020, this will be called the Research to Practice series and no longer Medical and Surgical Oncology. So we've done our sound checks. It's our start time. If you're experiencing any technical difficulties, please call us 919-445-1000. You can also reach us by email at unccn@unc.edu. If you need to know anything about our organization, past lectures, future lectures, lots of other things, we're at unccn.org. All right, and with that, I want to remind you that we will be using Poll Everywhere today. It's anonymous, it's free, it's easy to use. I encourage you to do this in one of three ways. You can join via the web. Just go to pollev, POLLEV.com, enter the letters UNCCN, and then you'll see the questions as they come up. You can join by text, by texting the letters UNCCN to the number 22333. And you'll get a message back that says join, and then you can answer. Additionally, you can just use your phone, and there's a free Poll Everywhere app, and I've been using that a lot lately. That works very well. We've got live lectures, self-paced online courses, media site library with well over 200 oncology lectures and lots of lectures on YouTube as well. So we invite you to join us at any of those locations. All right, and without further ado, I'm very pleased to have Dr. Andrew Wang joining us here today. Thank you so much for being here. So let's see what we know about you already, and then maybe you can tell us a little bit more. Since joining the UNC faculty in 2009, you've established a research program with a central theme of applying technology advances in physical sciences and engineering to oncology. Is that on target so far?
That sounds about right.
Good. And the central theme of your research program is to apply advances from other fields such as chemical engineering, material science, biomedical engineering, and nanotechnology to the field of oncology.
That's correct.
Great. Great. It sounds like you're a busy guy.
We have a lot of fun in the lab.
Good.
We make we need new therapeutics and diagnostics and try to improve our cancer treatment.
Great. And what's one thing outside of that professional bio that we should know about you?
Well, so a couple of things. One is we're house divided. My wife is a medical oncologist at Duke.
Very good. Very good.
And then we have three little ones. And they keep us busy. So no other hobbies other than that.
That sounds like that would fill every week.
Other than kids.
Yeah. Well, good for you. Thank you again for being here. I did mention Poll Everywhere. This first question's, as usual, a softball. Radiation oncology is a medical specialty that involves the controlled use of radiation to treat cancer, either for cure or to reduce pain and other symptoms caused by cancer. So if you believe the answer is true, you can put in an A or just click true. If you think this is wrong, go ahead and put in a B or click false, and we'll come back to that in a moment. We do have our obligatory disclosure. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. William Wood receives research support from Pfizer and Genentech, ended 12/18. Dr. James Coggill, MD, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Andrew Wang, MD, has no financial relationships with commercial interests. All right, and with that in mind, let's take a look at this Poll Everywhere poll and see what comes through. Now, I will say, Dr. Wang, that we do have a campus network outage going on right now, and we're able to work around that in some ways, but I'm guessing that Poll Everywhere may be getting held up by that right now, so we're not going to worry about the fact that we're not seeing that coming in. I'll encourage our audience, keep those questions coming in. If it looks like Poll Everywhere is still affected by the network outage when we get towards the end, I'll provide you with an email address, and hopefully you'll be able to submit some questions that way. Do be jotting down questions for Dr. Wang as we move through the presentation. And without further ado, recent advances in radiation oncology, and I'll pass the controls over to you.
Well, thank you. So it's a pleasure to to speak to you today. I would like to share some of the recent advances in clinical radiation oncology with you. So I do want to share some disclosures. These are not commercial interests that has any relevance to the talk today, but these are startups that I've founded and I'm sharing with you. Quick background on radiation oncology for those of you who are not familiar with our specialty. We're a key component of the cancer treatment. Really one of the three pillars of cancer care, together with surgery and medical oncology. Up to 60% of all cancer patients receive radiotherapy sometime during their illness. So we're widely utilized and commonly utilized. And we're both in the curative management of cancer, but also we also help with palliation of cancer symptoms. A little bit about my department, the UNC Radiation Oncology Department. We have 8 sites covering the state of North Carolina. The main campus is in Chapel Hill, but we also have 7 other sites, which I'll show you on a map in a bit. And our faculty is very big. We have 21 physicians, 15 PhD physicists, and we have a total of 12 linear accelerator machines. And we also have CyberKnife radiosurgery, tomotherapy. We also have HDR, LDR, brachytherapy capabilities. And lastly, we're one of the couple dozen centers that conduct intraoperative radiation. It's not a commonly done practice. So to show you our footprint, and so as I mentioned, we have Chapel Hill campus, but we also have a very large footprint in Wake County. But we also, goes out to the west side of the state. We have Caldwell, and then Rockingham up north. And unlike many other departments where the different locations are separate, we are a very unified department, and this facilitates our patient care. As each site is standardized against the main campus, and we can transfer patients and coordinate care in a very smooth, seamless way. So to tell you a little bit about the different technologies we offer, so the most common treatment for radiation is done through what we call LINAC machines. So these are linear accelerators that accelerate electrons and then generate X-rays. As I mentioned, we have 12 of these across the state. We also have the intraoperative radiation capability. So this is a machine that's in the operating room here at the main campus. And this allows us to deliver radiation to a specific area during surgery, and this minimizes toxicity and can treat patients that otherwise wouldn't have been able to treat it using conventional means. And we do this a lot, at least almost once a week. And then, as I mentioned, we also have a couple other type of treatments that we offer here. On the left is the CyberKnife radiosurgery machine. This is a very high-tech device that allows us to deliver very high-dose radiation to a very small area in a very precise way, and hence has the radiosurgery name to it. But it's not surgery. It's still radiation. It's done through X-rays. And on the right-hand side is a picture of what we call brachytherapy, and that is putting radioactive source directly into the tumor or into a person's body and near the tumor to treat the tumor. This, again, help us to reduce toxicity, provide treatment directly at the tumor. We do this both for prostate cancer as well as for gynecological cancers. Okay. So here's
And we have our first poll everywhere question. And I'm pleased to say that we do have poll everywhere working now. And we've already even got an answer in.
Yeah.
So which of the following statements about radiation oncology in North Carolina is false? A, 60% of cancer patients receive radiotherapy sometime during their illness. B, the UNC healthcare system features 8 RAD1 facilities. Or C, CyberKnife is a procedure that involved placing radioactive material inside your body. Let's give them 10 seconds or so to go ahead and respond for those who have not already responded. I think I was listening.
The results is perfect.
Closely enough, and we're getting some diversity of results. That's all right, too. Remember, which of these is false? All right. Dr. Wang, what sort of moving all over the place, but I think we're settling in with what you were looking for here. So what is the answer on this?
So the answer is the last one. So that's the incorrect statement. So brachytherapy is to place radioactive material inside of the body.
Right.
And you know, the A and B, I mean, really, you know, I see some confusion here, but we do have 8 sites across the state, and data suggests that you know, about 60% of patients will receive some type of radiation during their entire illness, whether that's in the curative setting or the palliative setting. Anyhow, okay.
All right.
Good.
On to the next. Thank you.
Right. So, for the rest of the talk, I'll share with you some of the recent concepts and advances in clinical radiation oncology that will help with patient care. So the first concept I want to share with you is oligometastasis. Let me first define that. So oligometastasis is a condition where a patient has metastatic disease or stage 4 cancer, but very few metastases in the body. And we've known for decades now that when patients have oligometastasis, there is a chance for cure, and treatment for these metastases can bring survival benefit. And the classic example is colorectal cancer patients with liver metastases, and aggressive treatment for the liver metastases can sometimes bring cure to the metastatic colorectal cancer or stage 4 cancer. And if not, it will still provide survival benefit. And so we have a long history of doing that. Also, another example would be brain metastases from lung cancer, which is quite common as well. The major challenge over the years has been how to adequately treat these oligometastases, because in the past, these treatments have been done through surgery, and which has one is feasibility, the other is morbidity with the treatment. And so over the last decade or so, there is a progression and advance in radiation oncology to utilize what we call stereotactic ablative body radiotherapy to treat these cancers, or SABR for short. It's very similar to what CyberKnife does. In fact, CyberKnife can provide SABR. It's just one technology that can provide SABR. There are other ways to do SABR as well, especially using just the regular Linux. And what really, make me want to discuss this topic with you is in the last couple years, a couple trials, well-designed studies have reported that solidified the role for radiation and or SABR in the management of oligometastasis. So the first study I want to share with you, and this was published in Lancet Oncology, is local consolidative therapy, which in this case is SABR, in oligometastatic and non-small cell lung cancer. And so in this trial is a randomized phase 2 trial. The trial criteria for oligometastasis is 3 or fewer metastases, and not including the primary tumor. In terms of lymph node metastases, these are counted collectively. That means they only count as one. So you can have several lymph nodes, but they only count as one metastasis. And these patients were randomized and assigned one-to-one to either local consolidative therapies, in this case would be mostly radiotherapy or SABR, or surgery in a small number of patients, with or without maintenance chemotherapy versus just maintenance treatment alone. And here's a schema for the trial. And so it's not a very large trial. It has 74 patients and 50 patients. As you can imagine, this is a difficult study to randomize. So about 45 patients were randomized, and it's one-to-one, so half and half. And they were treated according to the trial. And there were and these patients, the results were analyzed for progression-free survival and time to new lesion, as well as overall survival. So what's interesting and exciting is shown here. These are the survival curves for both overall and PFS. And as you can see, the patients who received local treatment for the oligometastatic disease had significantly better survival. And the survival is, the curves separate early, and it's a durable separation. And so this is very encouraging. Granted that this is not a randomized phase 3 data, this is a randomized phase 2. On the other hand, it is carefully studied, a beta small sample size, and this really highly suggestive of that local aggressive treatment, especially utilizing SABR for oligometastatic disease in non-small cell lung cancer, can bring survival benefit. Since SABR is routinely utilized, I think many of us have adopted this as standard of care for many patients, and so for those of you out there, I strongly encourage you to consider aggressive management of oligometastasis in these patients. And so further to further enhance this message, there was a separate trial that was reported. Again, it's a randomized phase 2 trial, and this was reported in the JAMA Oncology, also a very high-profile journal. This is a single institution randomized phase 2, as opposed to a multi-institution in the other study. This is an American study. The other one was a European one. And the maintenance chemotherapy, this is maintenance chemotherapy alone versus SABR, followed by maintenance chemotherapy. And the definition for oligometastasis is 5 or less metastatic sites. The study's primary endpoint was PFS improvement, progression-free survival benefit. And so this is a small study, like I said, 29 patients, half and half in each arm. Nonetheless, the survival curve, PFS survival curve, had a big separation and statistically significant. Again, suggestive or indicating a strong benefit to aggressive SABR or SBRT management for these oligometastases. So to summarize, oligometastasis management in non-small cell lung cancer can bring overall survival benefit. And I'm not going through here, but there is similar trial, similar data in other cancers such as prostate cancer. And this is a concept that is being actively studied and being expanded in many other cancers. So stay tuned for the other results. I would say that the reason that we're particularly enthusiastic about this concept is that SABR is very easy to do, unlike big open surgeries, and SABR can be done with limited toxicity and minimally invasive procedures. And then in this case, at UNC, we would utilize our CyberKnife machine for SABR treatment It is an excellent tool. It has onboard imaging. Typically, it only requires interventional radiology to place some markers into or near the tumor to track the tumor movement, and then we're able to conduct these. And if the tumor is near the spine, we actually don't need any intervention. We can use spine to guide the treatment. And as I mentioned, is just emphasize, the patients who fit the oligometastatic definition should be really considered for SABR or aggressive management of their metastatic disease. And if these metastases are easily accessible by surgery, and surgery is an excellent option as well. So this doesn't mean that you can only do SABR. I think it's just aggressive management for these patients, whichever means makes sense. And the definition I would adopt is just less than 5 metastases. and as I mentioned, there's growing data in this, so I would encourage everyone to stay up to date on this literature. And also, we will have future lectures that could provide updates for you.
All right, so now's your opportunity to see what you've learned about oligometastasis. And so which of the following statements about oligometastasis is false? And A, a condition with fewer metastases arising from tumors that have not acquired a potential for widespread metastasis. B is potentially curable disease and treatment can bring survival benefit. C is SABR treatment of oligometastasis. Help me out with this one. I had oligometastasis, but
Oligometastatic disease.
Metastatic disease in NSCLC appears to improve survival. Or D, brachytherapy is an excellent tool in SABR treatment. And we'll give them.
So which one's false? Now we're looking for false.
The statement says false. I had oligometastasis, but then when it got to the other form of the word. So, all right. How are they doing, Dr. Wang?
We're doing well. So, ABC are all true statements. So, really, so the biology of oligometastasis has been studied. So the idea is that oligometastatic disease represents a unique biology. And this is where a tumor got lucky. It was able to set up shop in a couple places. But the biology but it hasn't become so aggressive that it can go widespread in the body. So hence, if we wipe them out in these oligometastatic sites, we can still provide a survival and sometimes cure these patients. And this paradigm has been evolving for the past few decades, and it's becoming very mature. And oligometastatic disease is potentially a curable condition, and certainly, as I've shown, there's survival benefits. So B is true. SABR treatment, did show survival benefits. So C is true as well. Brachytherapy, so this is hard because it requires a little bit more knowledge about how to treat oligometastatic disease. But brachytherapy is really not a good tool for SABR treatment, largely because brachytherapy requires radioisotope placement into the tumor. That's invasive, and many times it has the same challenges as surgery. SABR treatment is predominantly or always done with big machines using X-rays. So D is the right answer.
D is the one that we're looking for. Is the wrong answer.
Right.
All right. Terrific. Okay. Thank you.
Okay. So so the next one, the concept I would like to bring up is the topic of using local radiation for low volume metastatic prostate cancer. So traditionally, our view for metastatic prostate cancer is that local treatment no longer provides benefit. Hence, when prostate cancer patients come in, present with metastatic disease, the treatment has always been hormone suppression or androgen suppression treatment, and local treatment is only conducted in the scenario of where they have symptoms. But this change, I think this was when this trial was reported late last year. I think this is a very exciting development, and I think it's a major change, and it can potentially it has major implications to how we manage these patients. So this is this was published in the Lancet. It is part of the STAMPEDE trial, studying using radiation to the local prostate tumor in patients who have metastatic prostate cancer but don't. Actually, in this case, they have high and low volume metastatic disease, but this is the upfront setting, so that these patients presented with a metastatic prostate cancer. By the way, for those of you who are not familiar, so the STAMPEDE trial, and this is done in England and as well as several other countries, is a very, very complex, large clinical trial. It has different arms. In some arms are studying chemotherapy questions, systemic therapy questions, and some arms are studying local treatment questions. So this is arm H, and each arm is a randomized study. So this is the arm H randomized phase 3 at 117 hospitals in Switzerland and UK. It's a randomization to standard of care, which is androgen suppression versus androgen suppression plus local radiation. So here is the schema for the trial. I just want to mention this is a very large trial, very large sample size, so over 2,000 patients were randomized. There's slightly variations in each treatment arm, but so what we're going to focus on is the analysis on survival and survival stratified by how much disease burden they have. And so, as you can see, the overall survival wasn't significantly different if you just compare the two arms, although the radiotherapy arm has a suggestion that it may have done a little bit better. Now, certainly the progression-free survival, there's a difference. But if we look at the survival based on the volume of disease patient present with, in low volume metastatic disease patients, local radiotherapy subgroup analysis of local radiation really provided a significant survival benefit in overall survival and also progression-free survival. Now, granted that this is subgroup analysis, so it's hypothesis generating, nonetheless, the data is very strong, and given the large sample size, I think most of us in the field believes that in low volume metastatic prostate cancer patients in the upfront setting, they should receive local radiation, and it should provide. It looks like it's providing a survival benefit. So key thing here is, how do we define low volume metastatic prostate cancer? This is defined in general by high volume is defined as 4 or more bone sites outside of the vertebral body and pelvis. And then visceral metastatic disease is also considered a high metastatic burden. And so everything else would be considered as low, so no visceral, and then 4 or less metastases. So I just want to add, though, is another indication for these patients, even if they have high volume metastatic disease, is if they have a strong, very significant locally obstructive symptoms. They have difficulty urinating despite androgen suppression, and that's a strong indication for local radiation as well. I don't want to make it just that low volume metastatic disease patients should get local prostate radiation. Patients with obstructive symptoms should also be palliated as well. Okay, so moving on. So on the topic of prostate cancer, so another development, so in this case, this is not for metastatic patients. These are the high-risk prostate cancer patients, and also high intermediate risk prostate cancer patients. This is the patient population where we do have it is a challenge to cure them of their disease. They do have very aggressive disease, have a high chance of progressing, and they're having prostate cancer causing their mortality. And this study was done in just north of us in Canada, and it's a large randomized study comparing increasing the radiation dose or dose escalation in the prostate using brachytherapy. These are the radioactive seeds that we can place within the prostate versus a standard of external beam radiation, how we normally treat prostate cancer in these aggressive patients. So again, this is a very large study, but although it's done in the same system, but multiple hospitals. What's interesting and exciting is that in this case, although there's no overall survival benefit, there's a very large difference in progression-free survival, or no evidence of prostate cancer at 9 years endpoint. So the difference in high-risk patients at 9 years post-treatment is 83% of patients who received the higher dose of radiation, in this case would be brachytherapy, did not have any evidence of disease versus I think it was 67% in the standard treatment arm, which is pretty consistent with historical data. And so this is highly significant. This suggests that increasing the radiation dose through the means of prostate low-dose rate brachytherapy can improve the treatment outcome in high-risk prostate cancer patients or high intermediate risk prostate cancer patients. So if you have a young prostate cancer patient or someone who has long life expectancy, say beyond 10 years, I strongly encourage everyone to consider the SBRT or dose escalation approach for their treatment. I do want to emphasize the point, though, is the brachytherapy, which is placing the radioactive seeds into the prostate. It is a procedure, should be done at a high volume place. This has been studied, decades ago, and given that it's a procedure, the quality of brachytherapy is highly dependent on the volume of the practice, and so I would encourage everyone to refer patients to a high volume center to improve the quality of the treatment, because the patient would not derive the benefit from this approach if the brachytherapy is not done appropriately, and it's not. And this is a challenging procedure, so I just want to put that in there. And so there's been a lot happening in the prostate cancer world. It's not just because this is one of my major focus, but really the science has evolved a lot in the last couple of years. And so this is fresh off the press. This was just reported at this year's ESMO about how we should manage patients who had surgery for prostate cancer. So we have, the field has struggled with this question for a long time. The idea is, so the question is adjuvant versus salvage, early salvage radiation. What I'm getting at is many patients would choose to receive surgery for their prostate cancer treatment. And post-surgery, many times we will find adverse features on the pathology, such as extracapsular extension, or positive surgical margin, or seminal vesicle invasion, and so on and so forth. And all of these features point towards a high chance for local recurrence, or distant recurrence for that matter. And in the past, there have been large trials, looking at adjuvant radiation. So that is, before you see any evidence of prostate cancer coming back, go ahead and give these patients a course of radiation to the local area to prevent recurrence. And these trials have shown a benefit versus nothing. And there's also trials that have looked at that, patients who waited until their PSA rose, become a non-zero number, and that indicates the cancer is coming back, and then giving radiation that time, and this is called salvage because we know they have a recurrence. And so we know that also provides benefit. But the question really wasn't answered, which is better? Do we go ahead and do it without waiting right after surgery, or do we wait until we see some PSA? Well, the Radical trial really tried to answer that question. As I mentioned, this was reported at ESMO, so the European Oncology meeting, and the publication we're still waiting for the publication. But in this case, they're comparing adjuvant versus early salvage. Early salvage means that PSA of about 0.2, or in this, in my mind, is anything above 0.1 would be early salvage.
All right, and so we already had a few folks reading this and putting their answers in. Okay. This is another question where you're looking for the false option in this case of the three. Which of the following statements about prostate cancer is false? A, low metastatic burden prostate cancer patients should be considered for local XRT, or B, patients with high risk or high intermediate risk prostate cancer should be considered for the Ascend-RT regimen, or C, patients with high risk or high intermediate risk prostate cancer, CyberKnife should be done at a high volume place as quality of CyberKnife is associated with volume. So take a little more time if you need to, maybe another 10 seconds or so if you have not had an opportunity to share what you think is the answer on this.
So we're looking for the false statement. What's wrong? The wrong statement.
I'm seeing things shifting a little bit here.
Not good. All right, so I would jump into it. So, so I want to, so clearly 50%, or okay, good, a little bit less now. So low metastatic burden prostate cancer patients should be considered for local radiation, and so A is true. So for those of you who felt that that's false, please, reconsider that and make sure that those patients at least hear the data and the opinion on local treatment for low volume metastatic disease. Luckily nobody said B was false. So then the last statement is wrong. CyberKnife is really not a good strategy to treat high-risk prostate cancer. CyberKnife is really utilized for low or low intermediate risk prostate cancer in the definitive setting. Okay. Sorry, I think I may have missed a slide. Just want to emphasize the point about the salvage and versus adjuvant. So basically, the trial said the early salvage won, and so we're waiting for the final data. But really, that you don't need. So we don't really need to do much adjuvant radiation at this point. So in patients who have surgery, even if you have adverse features, you don't need to send them to a radiation oncologist right away. You can wait until their PSA becomes non-zero. On the other hand, I wouldn't wait for PSA to rise much higher because the data is on early salvage. Sorry about that. Okay. The next concept that I would like to talk to you about is the intersection between radiation and cancer immunotherapy. I know everyone's familiar with immuno-oncology. It has really transformed how we manage many cancers, and has really provided very exciting data. And the synergy between radiation oncology and cancer immunotherapy was demonstrated early, way back in 2012. This was a New England Journal paper on a single patient. But what's unique is in this patient, she had metastatic melanoma. In fact, she had an initial response to CTLA-4 checkpoint, and then she was progressing. as part of the palliative management, she received SBRT or radiosurgery to a paraspinal mass. But what's remarkable was that not only the paraspinal mass shrank with radiation, the radiation elicits a more robust systemic immune response, and her immune system was able to eradicate all the rest of the tumor in her body that were progressing. And this effect that where you do a local treatment and then transform it into a systemic treatment, this phenomenon has been observed, first reported in the 1950s. It's called the episcopal effect. But even though it was reported in the 1950s, we rarely saw this. And with the immuno-oncology, we're seeing more and more, though it is not as frequent as we like. The idea behind the synergy is that radiation, we do a really good job at cancer cell killing. When we kill these tumor cells, the tumor cells release pro-inflammatory markers as well as the proteins inside of the cells. And this acts as another stimulation to the immune system. It lets the body immune system to better recognize the tumor cells and enable them to go after or attack the tumor cells. So many clinical studies have been trying to answer the question of does radiation really improve overall cancer immunotherapy outcome? And so this is a study that's answering in an indirect way. And so this was reported in Lancet Oncology. So looking at patients who were on Keynote 001 phase 1 trial receiving pembrolizumab for non-small cell lung cancer. And the way they analyzed the data was looking at patients who received radiation versus the patients who didn't receive the radiation during this trial. What's interesting is that the patients who received radiation here had a better survival compared to patients who didn't, which is suggestive that radiation has a benefit to immunotherapy. And in terms of the perhaps the most important is the side effects profile, because many of us who have patients who are on immunotherapy agents don't want to take them off immunotherapy agents because they're responding, and then there's strong concern that what if radiation would increase the side effects of immunotherapy, especially the autoimmune side effects. And so if you look at the side effects from these patients, what's comforting is that even though there is somewhat higher side effects in the radiation arm, there were no surprises, so to speak, or it wasn't significantly higher and worse in terms of autoimmune type of side effects. So therefore, I think it's safe to give radiation while patients are receiving immunotherapy agents. The somewhat nuanced in terms of detail, the different the special situation would be a brain metastasis, where we know that we probably have to tune down the dose for the brain treatment when patients are receiving IO agents, because there's a higher risk of necrosis. But as far as autoimmune toxicity, we're not seeing a dramatic increase or any evidence of radiation making that worse. And so another study in this space is the use of immunotherapy after chemoradiation for non-small cell lung cancer. So in this case, it's it's Durva that's being given. This was a New England Journal. So basically, the study examining the use of Durva in the adjuvant setting, which is after the chemoradiation treatment for stage 3 non-small cell lung cancer. So these patients have very poor outcome. What's amazing, as you can see in front of you or on the slides, is there's a major separation in the survival curve. So the use of the addition of durva after chemoradiation significantly improved the survival in this otherwise challenging population. And so, and again, this is the hazard ratio. So basically, it's pretty much across the board. Most patient, subgroups, there is a benefit to the addition of durva, and so this should be a standard of care for stage 3 non-small cell lung cancer. Okay, so all these data taken together, we can say that radiotherapy is synergistic with cancer immunotherapy, or it's favorable for the IO treatment regimens. There's growing data on how to best apply radiation to improve cancer immunotherapy. The data suggests that it's not just a simple, addition. There probably needs more sophistication in how we combine the two. Correlative studies or the science suggests that radiation indeed move the immune system to a more pro-inflammatory state. The effects is almost equivalent to a weak vaccine effect. I say weak is because we don't, move the needle entirely, but certainly we move the needle towards more pro-inflammatory, towards or favorable for the immune system to go after the cancer. There are some, more side effects with addition of radiation. That is a consideration. But on the other hand, the data suggests that patients can indeed remain on IO agents while they receive radiation, and that's very a good outcome, because there's just no evidence that radiation actually increases the autoimmune side effects, which are probably the most significant and concerning. Okay, so last but not least is we go touch on a little bit on the GI world. In this case, is the pancreatic cancer. This is the hardest cancer we have to manage in the GI oncology world. And the recent change is we're moving away from conventional daily radiation towards the SBRT or similar to, or another terminology for SABR type of treatment. So basically radiation focused, short course of radiation to the pancreatic cancer tumor itself. And what's the major difference? One is it's higher precision, higher dose, so shorter treatment duration, so each time we give more radiation. But we also treat less tissue. So we don't go after the lymph nodes typically. We don't go after a lot of the sites where, we used to think that we need to treat. And then the last is that it's more convenient. But some of these changes are both good and bad. So the higher dose and per fraction is potentially good for controlling smaller tumors, but it can also give more toxicity if the tumor is very big and it pushes on lots of normal organ. So a number of studies have looked at the use of the SBRT, the short course radiation, for pancreatic cancer management. So here's a very long list of clinical trials here. This ranges from Stanford trials to Harvard to Pitt, and all the way to Europe, Italian trial. And the regimens are slightly different, but the overall data is very consistent, which is when we give this treatment, we have a very high chance of controlling the disease in the pancreas or the pancreatic tumor that we see. Unfortunately, the patients still progress through because of systemic disease, but on the other hand, we do a very good local control with minimal toxicity, and we also can control the patient's pain. So this is the curve on pain control, which is quite significant. So our practice pattern have gradually evolved over the last few years away from like I said, is the conventional treatment, which has been shown to provide or hasn't been shown to provide significant benefit in multiple clinical trials, and especially the chemoradiation paradigm, just did not provide any positive data in this setting, and because of that, there's less and less reason to do the longer course, treat a larger volume, and that also has higher toxicity. So the current practice, especially the ASCO guidelines, provide is that we should seriously, not seriously consider, but really the smaller SBRT treatment for pancreas should be considered standard of care. And so that's another change in radiation oncology practice. All right, so that is really the what I want to share with you today. One topic I did not touch on is the head and neck cancer management, the changes in our dose escalation, for HPV positive head and neck cancer patients, and that's because Dr. Bisham Chira gave that talk several weeks ago, and so I don't want to repeat any of that. So to summarize what I shared with you, radiation oncology is an integral part of cancer treatment. Our indications really head to toe. I did not go through that. In cancer care, you should continue to consider us for both in the cure and also in the palliative setting. And the indications for radiations continue to evolve. As I shared with you, these are just some of the changes that's already happened in the last 2 years. We're finding that more and more patients can benefit from radiation treatment with these recent updates. Or in some cases, like the adjuvant salvage, some patients may not need radiation, and that's still a benefit. But it's all towards the better patient care. Well, thank you.
All right, and thank you. And I think we've got one more question here.
Okay.
I'm going to make a modification because I apologize. I mentioned that let's see, I'm going to borrow this for a moment as well. I mentioned that I thought that everybody could see Poll Everywhere, and it appears that our Zoom users cannot, so I'm going to see if I can fix that. Bear with me for just a moment here. I'm going to share my entire desktop, and let's see if we can address that, because we would like for you to see the questions for our Zoom users as well. Let's see, fingers crossed here. I'm going to hope that our Zoom users are able to see that now, and I'll read these carefully just in case anyone can't, because I know that makes it more difficult to answer if you can't see them all. But which of the following statements about radiation immunotherapy and SBRT use is false? Again, we're looking for the false one. Radiotherapy is not synergistic with cancer immunotherapy. B, radiation oncology is an integral part of cancer treatment. C, though it has a higher side effects, patients can remain on immunotherapy while receiving radiation. Or D, more patients can benefit from radiation treatments with recent updates. And we'll wait just a few more seconds for any more to come in. Think they're doing well?
Yeah.
Great.
Perfect score right now.
Great. So that's what we're looking for there. And again, I apologize that some of you were not able to see that on Zoom earlier. Hopefully you are now. I'm going to stop showing those responses, and I'll go ahead and activate our last poll. So you should be able to see that now, and that's where you're able to ask questions of Dr. Wang in just a minute. While we're waiting for those questions to come in, I want to thank our audience, thank all of you. This is the last lecture of 2019. We're so thankful that you're here today and that you've been at so many other lectures for most of you out there. We really appreciate that. Please spread the word in 2020. We want as many individuals as possible to be able to take advantage of this great information, this wealth of knowledge, and this free continuing education credit that's available. Thanks to the North Carolina General Assembly, thanks to the University Cancer Research Fund, thanks to the Lineberger Comprehensive Cancer Center, thanks to Mary King, Veneranda Obore, and John Powell for all of their help with this and every lecture. And now we get to this question place here. And while we're waiting to see if any questions come in, what's next for you? What do you see as being some of the frontiers, where we might be moving, and especially as we look to our North Carolina audience, what's next for North Carolina in radiation oncology?
Well, so overall in the broader field is I think the major advances that we can bring is really better identify strategies where how we can make radiation a really a robust how to best utilize radiation in immuno-oncology, really, to tune up the response. I think that has the highest potential to improve survival and curing in cancer patients. In terms of North Carolina, we have some exciting developments. Mostly, we're adding 2 superstar faculties in the coming year.
Great.
Shakina Elmore. Dr. Shakina Elmore is coming from Harvard, and she brings a very strong background and research portfolio in global oncology.
Okay.
And she's a cancer survivor herself. Amazing story. For those of you who want to read about it, there's a story on New England Journal called P53 and Me. And that's her. That's her story.
We'll look for that and we can put a link to that out in our next newsletter.
I get emotional every time I read it. So and then we have another faculty joining us, Dana, who is coming from Sloan Kettering. She will be despite she just finished her training, she's already a world expert on pediatrics and also translational research. So we also very excited to have her join us.
Great.
So team also our department is almost 50-50 men and women, and so that really helps with our diversity.
Yeah. Oh, that's great.
As well.
That's great. I'm seeing I think we're still seeing some issues with the poll, but it looks like, let's see if we can, I'll just read these to you since that, there we go. We were able to get it up on the screen. So to enhance the effect of immunotherapy, is any neo-XRT regimen used prior to immunotherapy?
Yeah, so I think what I'm getting at is, can you use radiation first prior to immunotherapy? Yeah, so I think those are so that's exactly what the Pacific trial is, and there are many studies looking at that, which is separating the immunotherapy and radiation temporally, so the radiation goes first and the immunotherapy goes second. So Pacific trial is already a success story, so we'll wait and see if others will report similar data.
Great.
So that's a great question.
Great.
The next question is, do nutrition and exercise affect radiation therapy? And the answer is absolutely. So I think nutrition is hard to know. Well, it's hard to see the clear effect. I mean, we do tell patients that obviously they need adequate nutrition to weather any sort of treatment. We actually tell patients not to do too much antioxidants, because that theoretically counters the radiation effect. For exercise, that's a very well established a phenomenon, which is that the more the patients exercise, provided that they're able to, the better off the better they can they deal with radiation side effects. The fatigue tend to be less. They tend to feel better. Any new data using radiotherapy in GBM? Yes and no. So the changes in GBM treatment is not exactly related to the change in radiation. Perhaps next year we can share some data. It's not as new, but the use of the tumor treating field in conjunction with radiation and temozolomide has improved GBM treatment. So for those who are not familiar with the tumor treating fields, this is a device where the patient will wear, and it's a large battery pack, and then they have probes on their head, and it creates an electrical field has effects on their brain, and it seems to really improve the radiation and temozolomide effects on GBM.
We actually did have a lecture probably a year or so ago on that device, so that is in our library as well.
Okay.
All right, coming up, the benefits of exercise for cancer patients. That'll be
Perfect.
January 8th, and then prostate cancer management in North Carolina, updates for 2020. So good lectures coming up, and always new courses coming online for our portal, where you can take these courses anytime, day or night. Tobacco treatment in cancer care and clinical trial update in head and neck cancer. So understanding pancreatic cancer, that's our next cancer conversations, January 24th. You can find out all of that information and more at unccn.org. Thank you so much.
Fantastic.
We really
It's a
appreciate
pleasure.
your time and expertise today. Thank you
thank
to our
you all.
audience. Happy holidays and a happy new year, and we look forward to seeing you in 2020.
Have a great holiday season, everyone.